นะคะเข้าสู่ IAEA Expert Mission นะคะ Strengthening Optimization in Radiological Practice ค่ะอาทิตย์นี้เป็นอาทิตย์ที่4แล้วนะคะซึ่งอาทิตย์นี้เราอยู่ในธีมของ CT นะคะแล้วเราจะมาพูดถึงในเรื่องของ CT ที่เราใช้กันเยอะมากเลยคือ CT ของ Body นะคะซึ่งก็คือทั้ง Chest Abdomen Pelvis นะคะว่าเราจะสามารถมีการ Optimization ในเรื่องของเทคนิคแล้วก็มีในเรื่องของ Dose Quality อะไรยังไงบ้างนะคะที่เราจะสามารถให้ได้ Image Quality ที่ดีสามารถ Diagnosis ได้นะคะแล้วก็สามารถลด Radiation Dose ได้ด้วยนะคะซึ่งก็เช่นเคยนะคะเราก็ได้รับเกียรติจาก Expert นะคะจาก IAEA นะคะดร. L Brady นะคะจาก Cincinnati Children's Hospital ที่จะมาเล่าให้เราฟังต่อนะคะว่าเราต้องทำอะไรยังไงบ้างแล้วก็เดี๋ยวมาเรียนรู้ร่วมกันนะคะ Good evening Sam we're gonna unmute you. Yeah. So good evening, Sam. Nice to meet you again. And I know this is very late. It's like at 10 p.m. in US time because of the daylight saving time. But thank you so much for continuing giving us a talk and teach us about the optimization in radiological practice. And so this is week 4 in the theme of the CT. We already talked about the DRL, how to establish the DRL, how to use it. And last week, we talked about CT of the neural part for head, mostly head, CT head. And this week, you're going to talk more about the CT abdomen, how to optimize imaging technique and reduce the radiation dose. So I give the stage to you to give a lecture. Mm-hmm.
Thank you very much. It's wonderful to be back with you. It is a little later for us here in the US. We have this crazy thing called daylight savings, but I am grateful to be here. So if I just fall over and fall asleep, I'll have Tanya just kind of text me and kick me or something.
Sure.
Anyway, so just like Tanya mentioned in the introduction, we've started down the path of CT. We've been talking about neuro last week. So today we're going to focus in on the body. But before we do, I actually made a promise. So there was right at the very end of our lecture series last week, we were discussing C-spines, which of course kind of sits right between the body and the head, and so but are always or almost always read by neuroradiologists and are typically grouped with with head protocols. And we were talking about having some reoccurring issues, mostly down in the C6, C7, T1, T2 area, and how when the C-spine is not properly optimized, you get this lack of conspicuity, you got lack of edge definition through the vertebral bodies. You get some pretty bad artifacting that obscures the cord. And so these are actually images from our scanner. And so this is something that I know a lot of people deal with. And so we talked about how we resolved this issue, but I wanted to give you some, there we go. I wanted to give you some more concrete examples of actually how to do this. So there was 2 main things that we did to help fix this problem. And so here, before I share with you how we fixed it, I'm going to share with you kind of what we were doing. So initially what would happen is our patients would be placed on the scanner, of course, and they'd have a scan localizer, would do an anterior, posterior, and then would do a lateral, which you see here. And from that, I am showing you obviously the lateral projection. And there are 2 plots that are overlaid this. They're a little hard to see. I know that especially this yellow one that kind of disappears into the white of the shoulder. But this yellow line right here tells you how attenuating or how thick these locations in the body are. And so this is more attenuating as it goes down through the chin and enters into the neck. It's not that attenuating. Of course, there's not a lot of material, not a lot of tissue in our neck. But then, of course, as it enters into the shoulder region, that's where the attenuation goes really, really high. In fact, we all know this. Anyone that's worked with CT long enough knows that most of the artifacts we get in CT are going to be in the shoulder. And then, of course, there are some down in the pelvis and here at the base of the skull. These are just probably the 3 most attenuating areas of our body because of the bony structure and then just the physical size of our body. And so you can see as the system when it measures the attenuation properties of the body using this localizer, it calculates how much radiation output it would need for the system to penetrate and create an image and reconstruct an image. And so initially, as it's passing through the face, the overall head, and even through the neck, it's pretty much nothing. It's zero. Well, not zero, but it's hitting the minimum MA that we have allowed the system to go. In fact, you can see here, I just wrote out a couple of them based on the actual physical location in this sagittal projection of the C-spine. So as it's going down through C1, C2, 3, 4, it's basically just hitting the minimum MA. But at that point, it needs to start to ramp up to get through the shoulder. And so it doubles here and it quadruples by the time it gets through the shoulder. But you can see, even though it's doubling and quadrupling, it's not quite enough output, not enough radiation for the system to faithfully reconstruct the anatomy here. And so that's why you're getting all this artifacting. So there's two things that we did to fix this. The first thing was we simply turned the machine around. We said, okay, well, we're going to start scanning from the shoulders and we're going to go towards the head. So instead of cranial-caudal, we're going to go caudal-cranial. You can see the attenuation profile in this patient, slightly different. It's a different patient, of course, but the attenuation property is basically the same. The shoulder, obviously really highly attenuating as it goes through the neck. It's not so much, and then through the head. And where possible, you can see this patient's a little bit more positioned. The neck is not so, the chin isn't so close to the neck, so it helps kind of stretch out the anatomy. Now, I know C-spines, the patients might be getting a C-spine and the neck may be compromised, so you may be just limited with what you can do to position the patient. But in this case, this patient's pretty well positioned. And by turning it around and going this way, now the system starts at the highest dose. In fact, you see this red line. This red line is actually the output. And the fact the system turns on and it realizes, hey, I need a lot of radiation, and it pushes it all the way through. And so you can actually see as it went from basically the T2 level up through the base of the skull, the dose actually in this case was the same. And the reason for that was we increased our minimum MA limit. So two things we did. We started the position to go up, and then in this case, because it's a Canon scanner, just like GE, you have to set a minimum and a maximum MA. In our previous one, we had, as you may recall, 25. It's a smaller patient, but nonetheless, our minimum MA was, a quarter of what we were doing now. And so we realized when we looked at our data, our image quality and our dose, it was just too low. And so we actually increased our minimum MA. And by increasing, you can see here, the system still used the minimum because it didn't feel like it needed more, but you can already see the improvement in the bony structure of the vertebral body. Everything seems just so much better than it was previously. In this case, this patient was even thicker through the shoulders. And so, excuse me, once again, starting from the caudal and going cranial, you see the attenuation profile is actually a very steep attenuation profile through the shoulders. And so the MA actually started much higher, here about 240, but it was able to, as it left the shoulders and entered into the neck and the head region, it was able to ramp down very quickly. And so, in fact, you see the steepness of this plot right here compared to, and I'm going to go back 2 slides, this is not as steep. And what we found was the system didn't ramp up the MA as fast as it could ramp down the MA. So it could go from 240 to 150 back down to its minimum very quickly. This is a thicker patient, and so the bony nature was still, the vertebral body was still very well visualized. There was maybe a little more translucence in nature in it, but still artifact-wise, it's much, much better than it had been. And so all right, sorry, those slides are out of order. So just quickly in summary for our C-spines, the two main things we did and that we talked about last week was we increased our minimum MA. So you just need to make sure you're actually using enough radiation. Too often we talk about reduce MA, reduce dose. We want to get as little as we can, but there is too low. That does exist. In pediatrics, which we are a pediatric hospital, too often people have talked about reducing the dose so low, but it actually makes it so that it can be at times very difficult for our radiologists to do their job. So we established a new minimum MA, and then by switching the angle and starting from the bottom and scanning up, it allowed the system to have a much more appropriate ramping time, and so the MA could match. And so we actually compared our profiles, our dose profiles, with several others. We get a lot of referral imaging, so we're able to compare with other hospitals around the nation. And after I normalized it here, you can see, so our doses are still lower than others in the US, but because we established, you can see here the angles, this gradient here is less steep than it is here. But now once we fixed it, the angles or the gradients were the same angle. So that was probably one of the biggest things to fix the issue. So anyway, I just wanted to give you some pictures of and give you actual some data, because we did physically talk about it, but we just didn't actually have any data to talk to you, to show you. So now switching back to actually the topic for today, which is body CT. So we're going to talk the trunk, chest, abdomen, pelvis. And so I showed you the very first neuro image ever acquired on a CT. It was back in, I think, 77, last week. And here I'm showing you the very first chest and the very first abdomen image. Now, these are clinical. They, of course, had done a lot of CT imaging on volunteers and on dogs and animals, but this was the first clinical system. That right there is Dr. Hounsfield, Godfrey Hounsfield. He is the one that essentially invented the CT scanner, and that's why we call our CT numbers Hounsfield units. It's named after him. And this gentleman, I'm drawing a blank on his name, he's a radiologist. He helped develop the clinical utility for the CT, and Hounsfield was the physicist, and obviously he developed the engineering side of it. But the point here is, look at those images. We have come a long way. And I made this comment last week, and I hope that you appreciate it even here looking at these images. The advancement of technology in CT will do more to change or improve the image quality and the dose reduction ability than really all of the small little knobs that we can twist. And so when you are fundamentally working with a CT scanner that's 10 years old or 15 years old, you're just going to be limited with how much image quality you can improve and how much dose you can reduce. It's fundamental because of the age of the technology. But as we go forward, about every 5 years, CTE technology makes a really big step forward. And so I'm not saying that we always need to buy a new scanner every 5 years, but I'm just saying that as we try to stay on the front of that technology wave, we have the ability to really harness a lot of the good image quality we have now in the low doses. And I showed you a lot of those pie charts last week about how, at least in the US, most of our doses in over a 10-year span have come down, even though utilization for the CT scans for the chest, head, all aspects of the body have gone up. And that's just mostly because of technology has been improved and we have been able to harness that technology. All right, so last week I demonstrated this interconnection figure. It's a web that basically takes the higher level goals of image quality, or really of just radiology in general. This idea that we need to establish the proper utility or appropriateness of the scans, and then how we establish that utility, we can then go all the way down to the left side of this plot, and you can see this long list of items that we need to optimize. We have obviously talked about, we've split up the two talks today. We're going to start with image quality, and then later we'll talk about dose. But you can see that image quality is only a small subsection of the optimization program. And obviously radiation dose is another one, actually an even smaller subsection, radiation dose being right here. So we went over the idea that we needed to optimize all of these values here. These are all the values that are directly connected to image quality. And so we did that for the head. So we're going to do that again today for the body. But I wanted to start off by asking this question. Excuse me. This list right here of, scan mode, KV, tube voltage, pitch, spatial resolution, you see down here, noise, all of these things that we talk about optimizing, how constant are they? If we were to measure them every day for a couple years, would those values be consistent in time, or would they drift? So this is a question I asked a couple years ago. And so what I did was every morning, our CT technologists, much like I assume your CT technologists do, is they place a phantom on the scanner. And part of the warm-up process and the calibration process is they scan that phantom. Now, I'm not 100% certain exactly what you all require your technologists to do, but one of the things that I developed, at least at our hospital, was I have them scan the phantom, and then, I ask them to make sure to look at it, just visually look at it, make sure there's no artifacts, there's no rings, there's no streaks, just it looks like a good quality image. And that gives them confidence that they know when they put the first patient on for the morning that the scan is going to look good. And then they send this image to me. It goes off to PACS, and PACS sends it to my computer. And I then I wrote some code that does a lot of analysis on it. And so what you're seeing here in just this plot specifically, you can see the days of this was last year, 2020. And so we used our CT scanner basically 340 something days. And every day they sent me this image, I was able to make a few measurements. And so here I measured the various different CT numbers for all the sensitometry, lung, water, IV enhanced or bone, soft tissue, kind of like muscle. And I wanted to see how constant they are. So I'm only showing you two things here. First, I'm showing you noise. And so this is the standard deviation of this yellow ROI. And so when you use the same water phantom every day, the system was consistently creating or calculating the same amount of noise. In other words, that when you dial in an MA or a KV, the system was very consistent in actually using that MA and KV to create this image, and therefore the noise was constant. The other thing was how consistent was the CT number. And water, as you all know, should be zero. Mathematically, it should be zero, but it's not always perfectly zero. So we allow it to be somewhere between plus or minus 3 or plus or minus 5 CT Hounsfield units. In this case, it's basically 1 consistently. And it kind of ran into this little blip right here for a couple of weeks back towards the end of last year. We had some issues with our CT scanner, but we worked them out, and you can see they all got back on a track. So when the system is functioning properly, which you would expect it to, you can see the CT number is consistent. Now, we also talked about noise power spectrum in our first week, which gives you an estimate of the total noise variance in the image and the texture of the noise. Is it going to be coarse and blobby, or is it going to be sandy, really fine? And so here I'm measuring the noise power spectrum in various different areas in the water. And that's what you can see here. The color of the plots correspond to the color of the ROIs over here. It doesn't really matter where I measured it, but basically I'm looking at the peak of this value. And looking at this peak, so you can see here, the red one dead center, it's somewhere just shy of 0.2 cycles per centimeter. And so you can see here over the course of the year, it varied a little bit between 0.15 and 0.2. In other words, the noise texture was consistent every day of the year, and the overall variance was pretty consistent. And then similarly, we wanted to know about the spatial resolution. Day in and day out, would the edges of the objects in our body, the bones, the maybe tubing, lines, whatever it is that has really strong edges, the edges, the capsules of our organs, all of these things, how consistently resolved or sharp would they be? And so that's what the modulation transfer function or the task transfer function calculates. And so here I just arbitrarily looked at the 50th percentile. So this value right here, if you draw a line over and you draw it down, it's somewhere in the 0.3 range, which is what you see here. And once again, there's a little bit of variability, and obviously the system kind of had some hard times there, but it got back onto track. But you can see that it's fairly consistent day in and day out. In other words, it's something that we would expect that our CT scanners would give us the same resolution every day. And then finally, the question really is, we've always talked about how we can calculate contrast to noise ratio, MTF, NPS. We can do all these really cool physics calculations, but what does that mean to the radiologist? Does their detection task change? And so here we talked about this idea of being able to have this detectability index, understanding exactly or predicting how well an individual like a radiologist is at a specific task. In this specific task, I am calculating their ability to look for soft tissue lesions and what is the minimum lesion size that they can see for at all different contrast levels and different tissue types. And in this case, when I put all the data from the previous 2 slides or 3 slides into it, the TTF, the NPS, all that, you can see it basically calculated kind of that minimum of 4 millimeters for everything. Now, obviously, at a little less, and this is perfect sensitivity. In other words, at all times, basically a radiologist would never have a problem finding a 4 millimeter object. And that's probably true anyway. But as they get smaller and smaller, obviously their sensitivity drops off to the point where it's 0.5, and 0.5 is a 50-50 guess. In other words, once it hits this x-axis down here, that's basically saying the radiologist is no better at guessing than they are. One radiologist can guess, and it's no better than the next radiologist guessing. Anyway, so the point here is even though we did see some variability in some of our measurements, because the system did have some troubles, you see in that same region, the sensitivity, the doctor sensitivity was predicted to be the same. And so I guess the take-home message for all of this is the fact that these scanners are very robust. And so once we've optimized them and we've tuned them, the system will actually perform pretty consistently over time. And like I mentioned, I've been doing this for about 1.5 years, 2 years now, and the data is just constant. And so it should give us a lot of confidence that the effort we put into optimizing means that those protocols will then continue to go forward as long as we, obviously use the system properly. So just as a quick reminder, when we talk about optimization, this isn't one person, this isn't a physicist, this isn't the radiologist, this is a team. Radiologist, technologist, physicist, and then as we talked about last week, having someone like from IT, computer savvy, that's able to help us make sure all the images are leaving the scanner and getting to PACS and getting from PACS over to the reading station. Everything gets where it needs to be. Every one of these people here, the individuals highlighted, they all have a very specific specialty that they are experts in. Radiologists obviously have the expertise in what they need to see. The technologists have the expertise in how to operate the system and to perform the task. The physicist has the expertise in the fundamentals of creating a system that can actually create those images. And of course, the PACS person helps the IT folks get the images where they need to. So in every respect, when we go through all of these slides, we have to think of how each one of these tasks is something that as a team we can approach. So here's a CT scanner stripped down without its covers. And when we talk about areas of optimization, we have that one long profile with all of the long list of things. Today, I thought I would just kind of strip it back a little bit and say, let's look at the major components of the CT scanner, especially for the body, and how do they affect image quality and patient dose. So we're going to talk physically about the actual generator, which is the thing that produces the energy to create the radiation. Obviously, the X-ray tube here connected to the generator, it obviously creates the X-rays. as the energy comes from the generator into the tube creates the X-rays through Bremsstrahlung radiation, and they come out and they go through a filter. We call it a bow tie filter. And then, of course, eventually they pass through the patient, where there would be a table here, and then it goes down to the detectors. And so the gantry holds this whole thing together. So when you can, and then of course we need the reconstruction software on the side that actually takes all that data and creates an image. So when we consider the head CT, which we talked about last week, most of us have the same size head. When you become an adult, as a function of age, even kids, basically at each, as they continue to grow, we all basically have the same size head. And it's all basically made of the same material. We got skin, a little bit of muscle, and a whole lot of bone in there. And so therefore, when it comes to optimization, we're typically using, when you consider this, we're typically using about the same output. We're using the same filter. We're usually using the same, although there was discussion of using a wide beam width, so a wide detector coverage versus a short. We talked a little bit about the reasons for those. But for the most part, the head didn't really truly require an optimization of all of these components. But in the body, of course, as a function of age, we are so much different. And even when we're all the same age, we can be quite a bit different in body habitus. And so there's a higher degree of variability, and therefore a greater need for optimization in the body. We use all kinds of different KVs and all kinds of different outputs. We use all different kinds of filters, and the detector needs to be optimized differently for slice thickness, for coverage, etc. So when we talk about optimization, let's kind of start back up at the top of the machine. The photons, the X-rays are coming out of the tube, and the very first thing they're going to do is they're going to pass through this filter. We call it a bow tie filter. It kind of looks like a typical bow tie that a gentleman might wear. And the reason we have the specific shape of this filter instead of it being just a flat filter is we are typically oval in nature. We have an elliptical a very generically elliptical shape, especially in the body, because we're talking body. And therefore, the photons that come directly out and straight out, down, and perpendicular from the tube, they're going to basically pass through probably some of the thickest material of our body. But yet those that are coming off on an angle will have very little material to pass through, because they'll be going through at an angle at the edges of our body. And so what we need to do is we need to equalize the photons as they come out. So we understand this. You guys have all learned this in your schooling. And so the bow tie filter is basically the inverse shape of our body. It's more attenuating on the edges and less attenuating in the middle, as we are less attenuating on the edges and more attenuating in the middle. The net result is that when the photons come through the bow tie filter and pass through our body, they will strike the detector, and the intensity will mostly be the same, assuming if this was like pure water. Obviously, there's slightly different if there's lungs and bones, but the idea is the spectrum is consistently the same. And so we equalize through the body, equalize through the periphery, and basically it helps us to maintain a good starting point. This is the most fundamental place to create a good image, is getting the right size filter, using the right size filter to create the image. Now, every system, every vendor has multiple choices and multiple options. Here is an example of one of our Canon machines. It's got, as you can see here, 5 options, going from large or double large or extra large to extra small. And so you can see these bow tie filters from a collimator. In this case, there's only 3. And so the technologist will have the opportunity to change this if they need to, because of the size of the patient, and that will help optimize the overall image quality by getting the right size filter for the right size patient. Now, the filter does more than just simply equalize the photons coming out. It also removes low energy radiation. Low energy radiation does nothing to contribute to image quality. All it is absorbed superficially in our body, maybe at the skin and the dermis level, which basically means radiation dose to the body, no benefit for image quality. And so having these rather thick bow tie filters allows us to actually reduce a lot of the unnecessary radiation dose to the body. But what that does, as you may recall from your days studying physics as a technologist or radiologist, is that when the photons pass through a filter, it absorbs all the low energies and only the higher energies or the more penetrating photons survive. And that means those have a higher, what's called half value layer. And so they're more penetrating. And the net benefit from that, and I hope you can see this difference, is the lung tissue here is a little bit more black, and the soft tissue is a little bit more, I would argue that there is more of a differential in the two contrasts here compared to the image here on the right, which it's a good image. You can still see the lung parenchyma, etc. But the intensity, the difference of the blacks and the whites is not as strong. And that is simply because as we have a higher or larger half value layer or more penetrative, a photon that has more penetrating ability, you get more distinctive contrast differential. You know, fats and soft tissues in the lung, and obviously soft tissue and bone. So, because of the unique nature of the bow tie filter, the most critical component of the day when you put the patient on the machine is getting that patient centered. When it comes down to it, dose and image quality are directly linked to where that person is within the bore. If they're off-centered, obviously here left to right, or if they're off-centered up to down, it will directly affect the dose, which we'll talk about in our next talk, and image quality, which we're going to talk about right now. So first of all, how does an off-centered patient directly affect our image quality? Well, here's an example. The center column represents an individual, in this case a phantom, that is well centered. And then you have on the left side a patient or phantom that is too superficially high, so it's closer to the x-ray tube. And then in this case, where the x-ray tube would be up here, in this case, with the x-ray tube up here, the patient is too low. So you can see here, centered, overall, the image quality is generally okay. But when you get off-centered, especially lower in the gantry, you get a lot of the streaking, the beam starvation, and you can kind of see some of this beam hardening artifact, this kind of darker blackish or dark gray areas, basically loss of signal. So the patients lower in the gantry lead to more artifacts. You know, you may argue there's a few artifacts in this compared to the center one, but off-center leads to greater artifacts. Now, we'll talk quite a bit about the dose on the next talk, but rest assured, those two, that patient being off-centered is directly going to affect the overall quality of the image. And so, like I said, the first thing when we're talking optimization, it doesn't always have to be a knob we turn. In this case, one of the great things we could do as an optimization team is we could make sure, we could work with our technologists, that our patients are always centered. The radiologist, obviously, when they get the images as they come across to the reading room, they'll be able to see if the patient is down, or they'll see the net effect of increased artifacts. And then also physicists and other quality assurance individuals, as you guys get Radiometrics and other tools, a lot of those will be able to calculate to see if the patient is too low. And so there are ways where we can optimize this by tracking and verifying that we're getting the patient centered. All right, so moving on. So what is so there's basically the two parameters. We have the patient on the table, the patient's nice and centered. And when the technologist sits down at the console, one of the basically two things that have been selected for them when they pull up the protocol is the KV and the MA. And we're going to talk about MA in a minute, so let's talk about KV. the tube potential. That is one of the fundamental things that are already set. So that's usually something the technologists don't change, which I'm not 100% certain how they do it in Thailand, but I can vouch for what I see here in the US as those are all predetermined in the protocols that are built by the optimization team. Most scanners nowadays have a very wide range of KVs. Historically, we've always had 80, 100, 120, and somewhere around 140. Some do 135, most do 140. Nowadays, with the enhancement in these X-ray tube and generators, we actually have opportunities to image at a wide variety of KVs, going from 70 up to 150. And we'll talk a little bit about why we'll use maybe 150 and 70 more next week when we talk dual energy. But for the most part now, we'll just focus on the standard 80, 100, 120, and 140. All right. So how does KV change the quality of the image? In this, I had a very basic, it's a water-based phantom, and it has these sensitometry rods in it. And so each one of these little inserts basically mimics a different tissue in our body. Obviously, you got bony anatomy, maybe contrast infused, vascularity, some lungs, air, soft tissue, maybe muscle. So it's all meant to be just kind of a way to calculate to see if the system can calculate the correct CT number for all of our various different tissue types. Here you can see I've selected 3 of them, 3 sensitometry rods, and I put a blue, a green, and a red box around them. And you will see that they correspond to these 3 plots in the same colors. And I scanned or imaged this phantom at different KVs, going from 140, 120, 180, and 70. I kept the MA, or the radiation output, the same or constant across all of these images. So there's a couple of things we can see. As we shift from high KV to low KV, the overall quality of the image or the noise content decreases. So you go, if you're not changing the MA, you're just simply changing the KV, the images get noisier. And you may argue that the texture does change slightly. You go from a kind of more of a finer noise to a more coarser noise. Okay, but we can handle that. We'll deal with that in a moment. But the other thing that changes is the actual value itself. So the CT number. As you go from high KV to low KV, the CT numbers do change. And so the only material that does not change is water. And this was basically, it's actually not a true water. It's actually a plastic-based water. And that's why you can see here it actually changes just slightly. But for the most part, it's pretty much close to 0. And so we'll call that not changing. And then, of course, fat changes and the bone changes. And so when we set the KV, we have to set 2 things. We need to set the right MA to accompany it so we don't have this crazy enhancement of noise. And then we also have to recognize the fact that the overall intensity of the image is going to change as we change KV. So what do I mean by that? Low KV imaging leads to better tissue contrast differentiation. So the lower the KV, what's causing this is we're getting more photoelectric absorption in the body. You may recall from your school days, photoelectric, Compton, pair production, all of those fun interactions, radiation interactions with tissue. Well, photoelectric effects happen at low energies and high atomic numbers. And so you can imagine anything with a high atomic number, such as IV and iodinated contrast or bony anatomy, how they're going to absorb more photons. And so they're going to have an inherently greater differentiation in tissue. So we will see a more intense differentiation between IV, iodinated contrast, and bony material from all other material in the body. And you can see here we have an iodine contrast injected into this patient, imaged at 120. In the liver, the vasculature is, you can still see it, it's definitely differentiated, but at the exact same same patient, but now imaged at 80 kV, the image, the iodine in the blood just it pops. It's way more intense, and that's because of this lifting from 140 to 80. You can see you've doubled the CT number. In other words, you've doubled the intensity of the signal. And then there's obviously just an overall differentiation from the water-based materials, the kind of the soft tissues that do not infuse with iodine. So here you can see muscles, maybe even some of the fats, but mostly muscle to soft tissue that is iodine, that has iodine infusion in it. You can see there's more differentiation. And so these are the two main reasons, obviously, why we inject IV, especially in the body, is so we can kind of see the vasculature and we can kind of start to differentiate the different tissue types. But it is much more intense and much more apparent at lower kV. So we can look at reducing the kV and doing one of two things. So if we take where our protocols that are typically in the body imaged at 120 kV, but now we move towards a, say, 100 or even an 80 kV value, one of the things we're going to do is we're going to improve the overall contrast to noise ratio. As you remember from the previous slide, it was just greater contrast. And we gain the ability for the same contrast to noise ratio and the same radiation dose level, we either improve the CNR, so we do decrease 120 to 100, and this curve goes up. Therefore, we get more intensity in the image. Or we can reduce the amount, or we can reduce the amount of IV oral contrast dose. And so we can go from, say, as an example, 10 milligrams per cc, which is what I used in this study, down to 2 milligrams per cc. And so by changing from 120 kV to 80 kV, the contrast per dose stayed the same. In other words, using a more diluted version of iodine, the image would still be the same intensity. It's just we've actually injected a little less iodine into the patient. So once again, to recap, you can either improve the intensity of it, just totally increase the intensity of the image, or we can actually try to mitigate a different kind of risk. We're not talking dose risk. We're talking we're talking an iodine dose risk. And so maybe someone has compromised kidneys, or we're talking a very young patient and we don't want to overburden or overload their system. Maybe you're doing a CTA. And so those tend to have a higher concentration and a higher overall dosing of iodine. But we could, if we just simply optimized our protocols at a lower kV, we could reduce some of that burden. Now, the only comment I make for that is this is mostly an effect that we can see in pediatrics. When you get up to adults, you can see these curves don't quite cross anymore. And so if I go from in this case, I was up to 135, but if I go up from 120 kV down to 80 kV, this curve never intersects with the 100, or it never intersects with any of the lower concentrations of iodine. In other words, to keep the same contrast to noise ratio per dose, I would actually have to increase my dose to actually make this work. And so this idea of diluting your contrast at lower kVs doesn't really make a lot of sense in adults. But for kids, which is probably the more risk, it's probably more sensitive population, it's something that you could consider if you were interested in. All right. So how do we know which kV to select? Well, you can go through and you can manually set the kV for every one of your protocols, which is kind of like, that is typically how we've done that for many, many years. But over the last probably about 5 or maybe even 6 or 7 years, most of the vendors, the CT vendors, have come out with a new technology that does auto kV selection. Now they call it all something different, kV assist, auto kV, etc. But the point here is forgive me. The point here is that the patient gets put on the scanner, and then what we're doing is we'll do a CT localizer scan, and the system will be able to measure the patient's thickness. And at the same time, the technologist will simply tell the scanner, okay, this is going to be either a non-contrast image, a contrast enhanced image, a soft tissue goal, we want to look at for soft tissue, or this is something where we're looking at bony anatomy only, like MSK type stuff, or we're looking for implants. And so the technologists would tell the system generically kind of what's the overall goal of the imaging. And then from that, the system will then pick the right KV to maximize the contrast to noise ratio. And this is done because in the background, there's a bunch of curves and stuff built into the scanner. And so the system already basically knows, as a function of patient size and a function of task, it knows which KV to select to optimize contrast to noise ratio. So there's a couple of comments about this. First of all, you absolutely need to build constraints into the system. When we got this system years ago and we looked at it, the first thing we knew was we did not want for our little kids the system to ever pick a higher KV. It's okay if it picked a lower KV, but never pick a higher. As you remember, when we went from 120 to 80 a couple slides ago, the contrast enhanced. And that's a good thing. Now, if the converse happens, you go from 120 higher, 135, 140, 150, the contrast will become more diminished. And so in this case, we never really wanted the system to go higher, even if it was a big patient. So that's a decision you have to make. But in our case, we just never wanted to use those high values. Now, once the KV is selected, you need to understand that it will use that same KV for the entire rest of the series. We will talk a little later in the next talk about tube current modulation. And so this is not tube current modulation. Tube current modulation changes the MA as the tube spins around the body. KV will, once the system picks a KV, let's say it picks 100 KV, that means from top to bottom, every series thereafter, they will always be imaged at 100 kV. So, is this beneficial? There was a study that was done in Boston, which is a state here in the US. And what they did at this hospital is they looked at 86 studies. And they basically compared them, they kind of broke them down based on the patient weight versus the protocol. And they said, okay, if this patient was 60 kilos, this patient was going to be imaged at 120 kV. If this patient was 40 kilos, this patient was going to be imaged at 100 kV. It's written into the protocol. That's just what it would what would happen if they used the protocol on the system. And then what they did is when they put the patient on the machine, they let the machine pick the kV. And so they compared it to what it would have been to what did happen. And what they found was that in 31 cases, a particular auto KV selection option, this is Care KV, it's a Siemens system. So it's the same, it'll be the same result for GE, Canon, and Siemens, but I'm just saying they used a Siemens system. So in 31 cases, their Care KV selected the same KV as had been written into the protocol. So in other words, there were no differences. But in 49 cases, the Care KV selected a lower KV. So the take-home message was, in general, we could probably image more often at a lower KV without any change to our image quality. Well, actually, it'd be an improvement of our image quality, but it wouldn't be a negative. We can go lower without having any issue. So if you use auto KV, that would help you get there. If you don't have that technology or you're not comfortable with that technology, then just consider the fact as an optimization team, you could go back and take a hard look at maybe your chest, abdomen, or pelvis protocols and say, if we're routinely doing everything at 120 kV, is there an actual population within a subpopulation in our patient group that could actually be imaged at a lower KV, such as smaller patients, thinner patients, patients that, for example, are going to get a CTA or kind of a contrast enhanced image. So what are some caveats to KV? The first is focal spot. You have to think about the actual size of the focal spot, which affects the spatial resolution in the image. If you want high resolution, fine structure imaging, you want to use the smallest focal spot available on the CT scanner. Almost all CT scanners limit the amount of MA that can be used for the small focal spot. Now, as you can imagine, if you have a really teeny small focal spot, so all of the radiation is being focused on a teeny little location on the X-ray tube target, that means a lot of heat is going to be at a very small area. So you can't just turn up the MA super high, you'll physically burn a hole in your X-ray tube. So most places will limit it roughly around 350 MA. Therefore, if the system needs more than 350 MA to create the image, the system will automatically change from a small focal spot to a large or an extra large. So why does that mean anything for KV? Well, we will talk about this more specifically in the next talk, but because we go down in KV, we typically need more MA to create a cleaner looking image. Remember, my image in my slide where I had five phantoms, and as I progressed from 140 down to 70 MA, once I got to the 70 MA, that image was really noisy, wasn't it? For a fixed MA. Therefore, as I decrease KV, I actually have to increase my MA. And if I'm constantly increasing my MA as I go lower and lower in KV, there's going to come a point where you're going to need more MA than 350. Therefore, lower KV imaging, especially when we're doing it in adults, because we can do a fair amount of 90 and 100 KV imaging in adults, almost always requires more than 350 MA. Therefore, you will be using a larger focal spot. It's a small price to pay, but know that if you need really fine imaging, so we're talking about maybe we're imaging a neonate or a little baby, or maybe we're doing MSK stuff where we're really looking at for fine hairline fractures in our bones. Well, in that case, you really want to make sure the MA never goes over 350. And so in that case, potentially, you keep the KV at 120. And therefore, the system would not need that higher MA. All right. Now, the other thing you have to optimize is the actual appearance of the image to our radiologists. So you have gone in, you've dialed your KV down, now you're routinely imaging, let's say at 100 KV or maybe even lower. You maybe even were able to reduce the contrast and concentration, the iodine concentration. I mean, you figured out all these optimizations that you've done. But when you actually acquire it at a lower KV, because of the intensity of the CT numbers, because they are different at lower KVs and higher KVs, the images will look different to the radiologist. So if you use the same soft tissue window width, and window level, remember what a window width is basically just telling you how many grayscales will be used to create that image on the monitor at any given time. And the window level value is simply you telling the system which tissues to focus on. So in this case, if we set a window level at 40, it's going to be kind of down here in the soft tissue, water, fat region. So it's going to really demonstrate good, strong detail in those tissues. But everything up here or down up here in the 1,000+ range for bone, and everything down here in that -1,000 something air, you will not be able to see any detail because it'll just be washed out, which is very true here, right? You can see the liver, the spleen, the kidneys, they're white light bulbs. So what happens here is you need to actually change your predefined window widths and window levels. So the first image that appears to a radiologist doesn't look like the one on the left, but it looks like the one on the right. So it's just one more value. And this is where the PACS IT person might need to help set that up. So the hanging protocols that the radiologists are so used to looking at, once you've changed your kV from 120 down to say 80 kV, now it appears and you can see a greater level of detail for all the soft tissue and the bony and iodinated contrast enhanced tissue. Okay, so we've talked about the patient on the machine. We've talked about kV as a button to change. The other one is how fast the X-ray tube will rotate or spin around the patient. All of our more modern scanners can go a minimum of 0.5 seconds. That's pretty much the minimum for even the older technology. But a lot of the newer ones can go 0.35, 0.275, 0.25. Some may even get down to 0.2 within the next year or so. That's pretty darn fast. And we talked about in head how we want to go as fast as we can. It's the same thing for the body. It is the same thing for the body. So here, it's probably even more critical in the body. In the head, yeah, there are some pulsatile issues with blood pulsing through the vessels, and obviously, the patient can have gross motion artifact by moving their head. But in the body, especially the thorax, there is involuntary motion that it's just we can't prevent. You can't tell you can tell the patient to take a deep breath, but you can't tell them to stop their heart for a moment. And so there is always going to be motion in this region. And so here is just one example of one of our patients where we acquired the images at a half-second rotation, which is pretty darn fast. But you can see this vessel right here. It's got the telltale sign of motion artifact. We call that the railroad track artifact or the track artifact. And here we imaged a different patient at 0.275, so a little faster. And here you can visualize this vessel. Very good and clean. And so what is this? This is simply freezing motion by imaging faster. So by doing volume mode, remember we talked about there are two vendors out there that sell scanners that can do 160 millimeters or 16 centimeter wide in a single rotation, which is pretty good. Generally speaking, that will cover the entire adult heart in one single rotation. Can't get much faster than that. But there are other machines that do helical imaging. Excuse me. And so the table is moving fast and the machine, the X-ray tube is moving fast. The two of them are moving really fast. And so we can get the patient through pretty quick too in these high helical modes. So better motion control equals better dose control. How is that? Well, that's just because we're not repeating our patient scans. And then this is just a quick reminder. Historically, most scanners operated around 4 centimeters or 40 millimeters. In fact, even some of our most advanced scanners that can do 160 are still actually operated at 40. Now, there's reasons for that, and I'm not going to get into all the detail. But wherein possible, if you can do a single rotation, say you're imaging the heart, or maybe you're doing just a more specific look at the kidneys, or if you have a little one, like a little neonate or a baby, oftentimes we can image a chest, an abdomen, or a pelvis all in one single rotation if we use this 160 millimeter option. So if we're not going to do volume mode, we're going to use helical mode, or not axial mode, we're going to do helical mode. And so to helical mode, as you all remember from your days in school, basically what's taking into account how fast the table is moving. This table feed per rotation, and it's divided by the overall total collimation, the number of detector elements and how physically small they are. So most of them are 0.5. One vendor has 0.625. And then they all come in a variety of and a number of different configurations. So let's take a couple of examples here. If the value is a pitch less than 1, then the X-ray tube is actually spinning faster than the table is moving. And so all parts of the body are partially scanned more than once. So here you can see the distance traveled by one couch during one rotation is 10 centimeters, but the width of the slice is, oh, that's a typo, 5 centimeters. And this is a actual total slice of 10 centimeters. So 5 divided by 10 is 0.5 or less than 1. And so this is great because it'll give you really good detail of the body. In fact, almost every one of our protocols are imaged at pitches less than 0.1, less than 1. Now, does that mean the doses are higher? I'll answer that in my next talk. Now, if the system has a pitch of 1, that means the distance traveled by the couch during one single rotation is going to be the exact same as the overall total collimation that you've established. So here is an example, 10 centimeters divided by 10, you get a pitch of 1. And then, of course, if the pitch is greater than 1, that means the tube spins slower than the table pushes through. And therefore, there are actual parts of the body that are not directly exposed to the x-rays. So we will answer the dose question in the next talk. What does change when we go from axial or volume mode to helical? Well, obviously, time. So if you dial a pitch greater than 1, the scan will be done faster. If you do a pitch less than 1, the scan will, by nature, go slower. Is image quality affected? It can be. There can be more artifacts from high pitch helical imaging. This is an interpolation artifact. If you're doing anything over a pitch of 1, well, there are parts of the body that are not directly scanned, but we still need to reconstruct those. Our radiologists don't want big gaps in their images. And so what we do is we will take a little bit of data from one slice of a scan and a little bit of data from another, and we'll combine it and average it. And that's how we create these slices in between that don't have a lot of data or are missing some data. And because of these interpolation artifacts, especially for really high pitch values, you can get what we call windmill artifacts. Now, these windmill artifacts are typically found usually at the bone air interfaces or where there's like a wire or a tube that's been inserted into the body. But to know that this right here is a direct effect of using a pitch of greater than 1. Now, as I mentioned, if we go less than 1, is there a change in image quality? And the answer is yes. Well, it may lead to improved image quality. It's usually typically, we use this because it oversamples the tissue and it really gives us good fine detail, not only in the transaxial view, but actually it makes the biggest difference when you're looking at your reformats, your sagittals and your coronals. So pitch less than 1 is actually oftentimes used. And as I mentioned, I'll tell you how it affects dose. Now, globally, helical imaging will always introduce a slight amount of blur in the image. So obviously here in the lungs, yeah, there's potential blur just because they may not hold their breath or the heart is moving, right? But if you actually look at the texture of the lung in this pretty good breath hold compared to the texture over here, excuse me, and even look at the edges of the muscle and soft tissue and fat boundaries, they're stronger or sharper in the axial. And that is because, why? In the axial image, the table's not moving. The patient stopped, the machine collects a picture, and the table moves again. And it stops, and then we collect another picture. Helical, the table is constantly moving as the machine is constantly spinning and collecting data. So there's never a point where the table is stationary, so there's always a little bit of a blur effect. Now, I would argue it's probably not that mission critical, that this is just a little bit of a softer edge, but you just need to understand that helical will have a slight amount of blur to it. So I'm going to do a quick summary of what we've covered so far, and then I have a few more slides to go over. So bow tie filter, we want the right size bow tie filter, and we want to make sure our patient is always centered in the scan field of view. We want to pick the right KV for the right task. And as much as possible, it's good to use the lower KVs. We want to image as fast as we possibly can. That's in general. The faster we go, the better we can capture, or we can we can mitigate motion effects, especially in the chest, where obviously we can ask them to hold their breath, but more so we can help, we can create an image where the cardiac motion can be minimized or even frozen if you're going fast enough. We want to, somewhat of the benefits of KV, of reduced KV, there is dose reduction, which I will talk about, and there's CNR improvement, and there's potential for reduction of IV oral contrast concentration. So there's a lot of benefits for going to lower KVs. There's actually probably more benefits than there are negatives. Reduced KV is best, as I've kind of mentioned, best optimized for imaging techniques that has some kind of contrast being introduced into the body. Angiograms, enterographies, urograms, contrast enhance, of course, chest and pelvis. That said, there is zero benefit from changing 120 kV down to 80 or any other kV when you're doing a non-contrast image. There's just no benefit because there's just not a lot of inherent difference in the contrast to begin with in the image. All right, so these are all functions that directly affect image quality and the radiation dose output. And so we mentioned all the way at the very beginning, and actually talked about this a lot more last week, is there are certain reconstruction principles that we can optimize there are certain acquisition parameters that we can optimize that have no effect on image quality. And actually, forgive me, I said that wrong. We can affect image quality without changing the radiation dose of the body. So we can actually make a very big positive change without needing to worry about overdosing or underdosing our patients. And then there are other techniques that we just talked about that have a direct bearing on image quality and radiation dose. So let's talk about CT reconstruction principles. In general, CT reconstruction principles, they can affect patient dose in two principal ways. One is the type of reconstruction kernel we choose to use to create the image, to reconstruct the image. So as an example, when we're in the chest, when we're doing an we're going to pick like a lung kernel, the Canon, Siemens, they typically have their reconstruction kernels are numbered instead of just labeled like they are in GE. But the higher the value, the sharper the kernel. In those cases, we can actually tolerate more image noise in the image, and therefore we can actually reduce the dose to our images, and we don't have to worry as much about using a lot of radiation to create a good-looking image with a sharp and edge-enhancing reconstruction kernel. Now, if we're looking at really soft tissue, kind of low contrast objects, then image noise is going to be a really big issue. And so we need to maximize the contrast to noise ratio. And therefore, we typically need to use more radiation when we use some of these soft tissue enhancing reconstruction kernels. Now, the type of reconstruction algorithm that we use doesn't necessarily change per se with dose, but it can help us reduce our dose. And so the typical that we've used forever and ever and ever is filter back projection. We'll talk about that. Today, the standard is digital reconstruction. And then, as I promised a couple weeks ago, I told you I would talk about deep learning reconstruction, which is the new, really awesome, amazing reconstruction algorithm out there that's going to change the way we look at CT, in my personal opinion. And those technologies, as we've gone from filter back projection all the way up to deep learning, they've allowed us the opportunity to lower our X-ray doses. And I'll show you how. So obviously I shared this with you. Obviously it was for the head, but I shared this with you last week. The idea that setting the various different reconstruction kernels directly affects how the image is created. And therefore we can actually tolerate a little bit more noise in this type of an image because the structure, the bony anatomy, is already got such a high contrast compared to the background. We don't have to worry about if there's a little bit more noise here. Whereas if we're doing soft tissue imaging, if you have a soft tissue lesion somewhere in here, a little bit of noise over that would just would obscure it. Sorry, my mouse is really sensitive today for some reason. I apologize. My slides keep going forward, progressing a little faster than I want on occasion. Okay, so I mentioned the reconstruction kernel is one, and then the reconstruction algorithm is the other. Just kind of looking at this little timeline here. The first CT scanner, clinical CT scanner, was back here in 1971. And from that time forward, basically till 2008, 2009, we used one reconstruction kernel, filter back projection. The main excuse me. The main reason for that is it was fast, and this was an era where computers were very slow. And when we moved into this new era of using iterative reconstruction, this required a much more intense computational power. And it wasn't really available to us until about 2010-ish, 2008, 2009, 2010. That's when computers got fast enough and powerful enough to introduce these new techniques. And these aren't new per se. You guys have been using them for probably better part of a decade on all your scanners. And each of the vendors, Canon, GE, Siemens, Philips, they all have their various flavors of them. So why did filter back projection last for so long? It was as fast as can be. We could make you could reconstruct head to toe hundreds of images in milliseconds, just very quick. But the biggest limitation for for filter back projection in CT is that when you create an image, filtered back projection, each one of the projected images, every angle that the CT scanner collects data as it spins around the body, every one of these angles, if it ever passes through a specific angle where there's a lot of noise, as an example, going laterally through our shoulders, that noise is propagated into every voxel, every pixel or voxel in the image. And it doesn't matter if you have an image, a projection that's going, say, anterior to posterior, which is going to be the least amount of attenuating in this specific slice, and therefore probably the easiest to penetrate and the least noisy or best looking image projection. But even though you have a really good, clean one projection, because you had a very, very poor projection on the lateral, that noise dominates. And so it doesn't matter how many good projections you have. If you just have one or two crummy projections, the image quality goes down. And that's why you have all of these streaking artifacts in filter back projection. So what we did is we introduced iterative reconstruction. Iterative reconstruction, its primary task was to reduce or lower the amount of noise in the image. And so when you look at, for example, I use, just as an example, we have Canon, so they use Aider 3D. They all have their different names, Acer V, Aider, Sapphire, Admire, IDOS 4. I know you guys have probably all of the major vendors also in Thailand. I know specifically you do in Bangkok because I've seen them all. And so irrespective of what they're called, these iterative reconstruction techniques, they did a phenomenal job reducing the magnitude of the noise power spectrum, reducing the variance or the noise in the image. And that's a wonderful thing. But an unintended consequence that no one saw happen until they put them on the scanner and we started measuring these things is I remember when I first saw them, and the radiologist would say, these images look a little blurry. They look a little soft. And they couldn't quite figure out why until we started tearing into it and doing some fun physics. And we realized when you look at the noise power spectrum, the peak or mean of this filter back projected spectrum shifted left. And so here you see the mean is lower. Therefore, the texture changed also. You're going to say, okay, well, it's fine. The texture changed. Why is that a bad thing? If you look at the way our eye responds to resolution, our eye is optimized for this middle to kind of higher resolution range. When objects are too close together and too sharp, our eyes actually lose a little bit of sensitivity to our ability to distinguish those edges. But it's even worse when the edges get blurrier and more coarse. And so this lateral shift to the left of these curves simply put the reconstructed image distinctly in a region where our eyes, more specifically the radiologist's eyes, have a harder time perceiving edges or resolution. And so that is why the image quality, as I'll show you in a minute, actually looks just a little softer in iterative reconstruction compared to filter back projection. All right, so to overcome that, fast forward 10 years to, well, basically last year in 2019 and 2020, we came out with these new deep learning iterative reconstruction techniques. And what is deep learning? It is just a fancy name for computer algorithm. Basically what it is it's a network of computer, it's software that tries to mimic the way our brains work. Our brains have obviously lots of little neurons and nodes all firing. And so when I'm moving my finger, I'm getting a lot of electrical impulses that go up and they fire, and there's a bunch of neurons that work, and they all work in concert so that my body will know how to move or talk or think or breathe. Well, we can create software that has these same type of neural connections. And so it has a way of taking an image, decomposing it into its most basic structure, learning about that basic structure and putting it back together. And that's what a neural network is. So deep learning is that network right here. And what we do is we need to train that network. We need to train it to find something specific. It's one thing to just take that image and break it down to its teeny little pixel values and then put it all back together. But if we do that, and as we're taking it apart layer by layer by layer, and we're trying to teach it to find something, for example, noise, then the system becomes exceptionally good at figuring out what is noise and what is not. And so we train the system by giving it a lot of really good looking, high quality, low noise images. And we give it those same images, but very low quality, low dose, just ugly. These are images out here on the left that no radiologist want to look at. And as we send both of those images into this neural network, the system immediately goes, oh, I know what's different. It's the noise. And so we've trained this network. Now, when the patient climbs on the scanner, goes through, it takes the image and it immediately takes it apart and goes, okay, here's the noise and here's the anatomy. And it puts it back together without the noise. And that's basically what deep learning is. And it's just phenomenal in the quality and the direction we've been able to go with our iterative reconstruction over time. So filter back projection here on the left. There are two different flavors or styles of iterative reconstruction. Primarily the one you use and everyone uses is something called statistical iterative reconstruction. And so it's like your AIDRs, your ACER-Vs, your Admires and whatnot. There are other ones out there that tried to harness more power. They just kept trying to add to it to make them better. And I would argue that this image is a little bit more coarse, it's blurrier. The pixels tend to be more blobbish, more smudged. And so the overall pleasing nature of this image is a lot lower compared to, obviously this is too noisy, but the edges are sharper and crisper over there. So what if we can just simply take that noise out, but not affect the edges? And that is what deep learning's done. And here you can see for a 3mm reconstructed image, this is what you would probably, this image right here that I'm circling with my arrow, that is what our radiologist looked at consistently for a decade, from basically 2008, 2009 up to 2019. And when we were working with Canon on developing this, we got these images here, and you can see here now just the quality of the image. It's reduced in dose, and it's even improved if you looked at the thinnest of images, the 0.5mm images. Yeah, still a little noisy, but compared to where it was, it's just so much cleaner. So let's drill it down. Compare it to where we were a year ago to where we are personally now today. So by simply just turning on this algorithm, it works on top of all the other algorithms that we have going on. filter back projection. The very first image the technologists see on the console that appears in front of them, that is always filter back projection. And then iterative reconstruction cleans that up within about 20, 30 seconds. And so they're seeing a cleaner image. And then the images that we oftentimes will send to the radiologist will be these nice images, but noisy. And then we apply the deep learning on top of that, and we get this nice clean image. Now, did deep learning, what was the biggest benefit? Well, I mentioned that when you look at these deep learning images, high versus low, it's simply finding the noise and removing it. And so there's really no edges in here. You can't see an outline of a bone or an outline of the myocardium, the lung area, and I guess, the heart and whatnot. You don't see any outlines here in this noise plot, which means that the edges were never subtracted, never removed. It's just simply the difference between these two images. The higher dose, less noise, and the lower dose, noisy image is simply the noise itself. So it is very good at finding noise patterns and removing them. These deep learning algorithms are built up, and they are have been inserted into the iterative reconstruction process. So therefore, we actually call them deep learning iterative reconstruction algorithms. There are two major vendors out there, GE and Canon, that have this algorithm for sale, and it's something you can eventually put on like your Genesis and your GE Revolution or Apex scanners. And these two vendors come with multiple different options. Usually you can apply a mild, a standard, or an even stronger amount of noise reduction. And so for some people, this may look a little it may look a little foreign because there's not a lot, if any, noise overlaying this image. And they look at this, and most radiologists would see this image and they feel more comfortable with it, even though the only difference between these two images is the noise variation, but it just gives it more of a pleasing look to the eye just because that's what they've been trained to look at. And so most places have been just immediately using the standard or the middle option, medium or standard. Canon additionally created different reconstruction algorithms for different parts of the body or different applications, such as body, lung, bone, or cardiac. And so then the other question is, we've been talking about how these new technologies, they've improved spatial resolution, they're reducing the noise power spectrum effects, they're improving contrast. These are all quote unquote physics metrics that we've talked about that make sense to us when we're trying to ask the question, is this algorithm, is this protocol, is this scanner better than something else as a comparison? But the real question we really want to know is, do all of these changes have some kind of direct correlation with the improvement in detection accuracy, radiologist sensitivity and specificity, and classification and detectability? And so this side of the equation is, how well does a radiologist perform if we modify these objects over here? So now that we have all these new technologies, one of the things we've been trying to do is we're looking at various different applications, and we're going out and we're starting to ask ourselves, do we improve detection sensitivity? As an example, we just looked at a very simple task with something we wanted to know. And so we looked at being able to count stones in the kidneys. Were they able to have a greater efficiency or sensitivity to detect stones of all different sizes, and did it change the number of stones that they could detect based on the various different deep learning algorithms out there? So we did a reader observer study where we took in this case 3 radiologists. We had them look at 84 total exams, basically 14 patient exams that we reconstructed using the various different strengths and different types of the deep learning iterative reconstruction algorithms. And in our case, of course, we're pediatrics, so the preponderance of our kids were late teenagers. And the values that we found for the radiologists was they almost agreed completely in every case. A kappa value of 0.7 and a 1. Basically, a kappa of 1 means there's perfect agreement. And so there were times where they perfectly agreed on all of the images, on some of the images they looked at. In other case, there was slight difference, but a kappa of 0.7 is a strong agreement. So it's anything over, I think, like a 0.6 or a 0.55. This is a very strong, good agreement. So in this case, we found there was really no statistical difference between the old way we did it with the iterative reconstruction and the deep learning. So not quite necessarily the slam dunk or the, for us, kind of the home run. We didn't really see a great improvement in detection sensitivity. Mind you, this was looking at a high contrast object, such as a stone. There are other projects, of course, since it's such a new technology, we're looking at all types of things, tumors and, metastatic disease, infection, all this subtle stuff that we see see in the body that may be improved by the use of these new deep learning algorithms. So summarizing what we've been talking about with reconstruction algorithms, iterative reconstruction has fundamentally replaced filter back rejection. And I would argue probably in the next 5 years, deep learning algorithms will fundamentally completely replace iterative reconstruction algorithms. Advantages, of course, they reduce image noise, they reduce image artifacts. The disadvantage that I demonstrated was noise texture changes. Images can be softer and they will appear softer to our eyes just because of the way our eyes work. And I didn't really talk about this, but they do take a little bit longer to reconstruct. I alluded to it because we needed faster computers. I would argue that even though it's a disadvantage, it's not that big of one. It only adds maybe 40, 50 seconds to your reconstruction time. Something that a radiologist will never see, because by the time the scan is complete and sent off to PACS and the radiologists have a time to go through their work list and pull it up, that's not an issue. We're talking minutes to tens of minutes for a radiologist, whereas on these scanners, we went from milliseconds to maybe a couple seconds to a couple minutes. And then, like I said, deep learning iterative reconstruction advantages. They once again also improve the image noise artifacts even more so than iterative reconstruction. And we haven't really found any true impact on, the diagnostic ability, the sensitivity, but I'm sure we'll find that as we continue to go forward. All right. This talk was a little bit longer, and so my next talk won't be as long. So I know we went over a little bit in our timing scheme. And so if we still want to take the full amount of time for questions and answers, I just wanted to let you know, Tanya, that my next talk is actually not going to be as long, so we'll still end on time total.
Okay, sounds good to me. Thank you so much for simplifying things for us. Yeah. So ถ้าใครมีคำถามนะคะสามารถยกมือขึ้นมาได้นะคะใน Zoom แล้วเดี๋ยวจะเปิดให้สามารถพูดได้นะคะ So any questions that you guys have, you can type in the chat box or also raise your hand and I can unmute you. And today we also have Dr. Pan Rutais who's going to join us as a moderator for question and answer session. I have a couple questions. So for clarifications, I think the main things for us as a radiologist, we want to detect the lesions. So which means we need a good signal to noise ratio. And there are many ways to make a good signal to noise ratio, including low KV or increased the iodine concentration on the images, right? And after that, we have like a multiple physics stuff, maybe like a pitch or scan and everything. But the key things that we need is good signal to noise ratio. Is that correct?
Yes. When it comes down to, if you have a lesion that is enhancing, so we've got iodine on board, one of the best ways that we have found over the last couple of years is to reduce our image with lower KV. And probably 10 years ago, our scanners couldn't do that. They weren't strong enough. They weren't powerful enough. But nowadays, the more modern scanners, they have the ability, the generators are strong enough that we can put out enough MA, which we're going to talk about, because when you go low KV, you do need to increase the overall amount of MA or your image gets real noisy. So if you don't fix your MA, the lesion might be more strong, that signal might be stronger, but it would just be obscured with noise. And so we have to make sure we keep the image noise down, but with that lower KV, the conspicuity of those lesions will just kind of pop out a little bit more. And so two things: we lower our KV, which is a great way to go. And then as you have the ability in time, you obviously have iterative reconstruction now that cleans up noise. But with the deep learning algorithm, which is really kind of the future in the next couple of years, I think everyone will have that. That is going to, because that takes the noise completely out of it. It might take a little bit of our radiologists learning to look at a slightly different image. They are going to have to kind of recalibrate their eyes a little bit to look at an image without noise. But once they get used to that, I think they're going to start seeing even just small micro findings that they're not used to seeing, because they always would say, is that noise or is that a lesion? Is that infection? Is that noise? But now that you take that noise out, hopefully it becomes very obvious, even if it's not enhancing and like certain lesions are.
So that means in the future, when we have a good imaging reconstruction like deep learning, we can even lower the radiation dose to the patient because we can do like a post-processing technique.
Yep, I'm definitely going to talk about that in my next talk. But the answer is yes, we can do that. So yes, if we want to continue to reduce, quote unquote, the risk by reducing radiation, definitely yes. I would argue, and that's why I'll show you some pictures, I would argue we're kind of pretty low dose already. Most of the time. I mean, Dr. Panu Thai and everyone did a great job when we reviewed the Thai DLR values. Mm-hmm. Thailand, when you compare your national DLR values, you were kind of at the middle or actually lower than most of the countries around you. You know, when you looked at Japan and a few others, they were much higher, and South Korea is a little lower. But for the most part, you guys are doing great when it comes to radiation dose. Can you improve a little? I'm sure we can always improve, right? Now, the whole goal of the DLR program in Thailand is to get all of the hospitals all over Thailand to try to conform to that national value. And once you all are kind of in that value, in that range, then quote unquote, your risk is pretty equivalent, and I would argue decently low for all Thai people. And so we want to keep it, that's the whole idea of DLRs, is to try to keep the risk the same no matter where you get your imaging. Now, you may say, yeah, it's high, it's okay, but could we go lower? And we'll talk a little bit about that in the next talk. But there are times when we just don't need a lot of radiation to image. In other words, let's say we're looking at coronary heart disease. And so we're doing a calcium score. And we'll talk about cardiac next week. So it's probably a bad example. But calcium scoring is a very easy thing to see because it's contrast enhanced, and there's calcium, calcification in the vessels. And so it just pops. We don't need a lot of radiation. Now, on the converse side of that, let's say we have a patient that presents with an infection, fever, they have all these other issues. So we're thinking maybe there's, could be cancer. So we did a scan of the abdomen. We're looking at the liver. We're looking for low contrast, small mets. We're maybe even looking for, if we have a patient that's been on chemo, we're looking for infection, small and focal spots for infection. Those are things those are just hard to see. And so what is the risk there? Well, the risk is the radiologist missing the disease. And so that case, then maybe using a little bit more radiation is probably okay. It's actually probably the best thing to do. And so that's why that deep learning and iterative reconstruction, we can do it both ways. We can improve the image quality and get what we need without changing the dose, or we could actually keep the image quality where we're at and drop the dose some more. But I have some slides on that. We'll go over that in a minute.
There's a question in the chat from the audience.
All right, let's see. Regarding the bow tie issue, if we want to image the spine that located posteriorly of the body, we should position the torso at the center of the position, or position the spine at the center of the gantry. And then they also ask, as well as the cardiac bow tie, we should place the patient at center or place the heart at the center of the gantry. So those are great questions. So let's start with the first one, the spine. So we all know, yeah. So when we image and we place the body at the center, the spine is actually going to be a little bit lower. Now, if we center it on the body, what's going to happen, and we're going to talk about that in this next talk about the dose. If we center it on the body, that means the overall body will get the right amount of dose. If we push the patient up so that the spine is centered, what we've actually done is we've increased the overall dose to the patient. And I have some examples on that. So I'll show that in a moment. And so what we should do is we should always center the patient. Now there are times, and so you'll center the patient, and that will keep it so you don't get those imaging artifacts. If you have it a little too low, then especially if you're doing spine imaging, you get that streaking artifacts, and that just doesn't look good, especially when the radiologist is trying to read through that. Now the caveat to that is when they built these scanning tables, they made them so that they're curved, right? They thought they would be more comfortable for patients, and they probably are, instead of laying on a flat, hard surface. But the problem is when they made them curved, our bodies fall into them. And so technologists are really good at this, but when they go in to line up the patient, there's going to be a part of the body that's literally below the surface. And so it's hard to know exactly where is the center of the patient. A lot of the newer scanners, and I didn't show this image because it's really only on the newer scanners, they will, when you do your localizing CT, it will tell you where the center of the body is, and it will tell you where the center of the gantry is. And so if they're not lined up, you can push a button on your scanner and it'll move the table up or down, or you have to walk in physically and move it up or down. But that's nice. So going forward in the next probably 5 years or so, every scanner is going to have that, where you'll go in, you'll get them as best as you can centered on the scanner, and then you'll walk out of the room, and then you'll do the localizer, and then the system will know to move it up or down. But I have some more examples of that, so we'll kind of talk a little bit about that in the next one. But then the other one is the heart, and that is kind of tricky, is because you have to get the patient centered into the body. If you off-center the patient, well, I guess you off-center them this way, so you get the heart at the center. But the problem is, if you look at it now, my body is off-centered to the bow tie. And by off-centering to the bow tie, you're actually going to increase the amount of artifact at the edges of your body. And so even though you've put the heart at the center, you're actually putting a less thick part of the body centered over the thinnest part of the filter. And so it throws off the way the image is captured at the detector. And so it's still best to keep the body nice and centered. So centered up and down, left and right. And from that, then you can go in and you can set your field of view. You might actually only set your field of view around the heart, or you might set your field of view even thinner around the spine. But always keep the body itself centered.
So does it mean we need to put every patient in the center to reduce artifacts and reduce the radiation dose, have optimal radiation dose to the patient, and then we can adjust or change the display field of view to get a better image, to see more detail?
Yes.
Yeah.
And about the same question for the baby, very small, and the table cannot move up to the center. So how do you manage that?
Yeah, we used blankets. When you have a teeny little kid and these tables have this big bow to them, you put the baby into it, the baby disappears. And so, yeah, when we have little kids, we will actually, I've seen some places, some hospitals will actually use a flat table, but that's just that's hard, because then you'd have to change the tabletops. What we do is we just put a couple blankets down. So when you put the baby on it, they don't sink down into it. They just sit on top of the blankets. You just need to make sure you use blankets, though. If you're putting something in there that's heavy or hard, then it could cause artifacts. But blankets are, they're air equivalent, and so there's not an issue.
Another interesting questions from the chat box.
Yeah, there's another question.
For the low kV technique in CT that help to enhance the iodine enhancement, the question is, in case of chest and lung screening protocol, which is non-contrast study, should we use the low kV or the conventional kV at 120?
It's a good question. So if you are doing a non-contrast image, a non-contrast CT, if you lower the kV, you are not enhancing the contrast. There's just nothing to enhance. And so there's nothing to change. It's all the same, basically, CT number. The only reason you would want to use a lower kV in screening CT, so this is where you're doing a screening CT, where you're trying to do the lowest dose possible because you're imaging a very large amount of people. This is the one example why using a non-contrast CT, you could use like an 80 kV. And that's only because you're reducing the dose. If you go from 120 down to 80 kV, you're not going to enhance the image quality, but you are going to reduce the patient dose. And we will talk, unfortunately, we haven't talked about the dose yet, but we will talk about that in the next talk. So I did say that there's really no benefit to lower kV for non-contrast. I would say that there is no benefit for low kV imaging when you're doing, for example, a non-contrast abdomen or non-contrast pelvis, because we don't really screen. We don't do CT screening for abdomen pelvis. But in the chest, that's become very common, for smoking and whatnot, for lung disease. We've been most places, especially in Thailand and US, we do CT screening of the chest. And so we do really, really low kV, low MA, and it's okay because the air in the lungs and the lung tissue, it's already so contrasty, so different that you as the radiologist or you radiologists are able to still see if there's a little nodule or there's something in the lungs, even if it's a low quality image. So that's a great question. And thank you for clarifying, because you may have misinterpreted what I was saying when I said don't do low kV for non-contrast images.
It's normal populations, and we don't want to give too much radiation to the normal population, right? That is the key.
Yeah, and especially if if they have a history of smoking, and now they're going to start going in, I don't know, once a year or once every other year, depending on what the protocol is. If they're going in to get a CT chest for the next 20 years of their life, we don't need to use a lot of radiation. We don't want to, especially for women. Obviously they have breast tissue that's more radiosensitive. And then we all know that most of the tissue that is more sensitive to radiation, lung, breast, stomach, we got a lot of that in the chest area. And so we have to be a little bit more cautious when we image the chest.
May I ask a little about the kernel? I don't quite understand that. Is it applied before scanning or after scanning, or can do at either of them when we select kernel?
Mm-hmm. So when we select, the kernel, the beautiful thing about reconstruction kernels is when we acquire the image, we can actually go through and change it. In fact, you as a radiologist, you could see the image and say, oh, I want to see something different. And so you could actually ask the technologist to change the kernel and send a new reconstruction to PACS for you to review. So the caveat to that is, go ahead, Panutai.
I would like to know, can we say that we want the kernel first from the beginning before the scanning?
Yeah.
Right?
Yeah. So the caveat to that is, if you're going to do a soft tissue reconstruction kernel, you need to set the dose at first to match that kernel. And so that's where you have to understand the task. If I'm going to be imaging the abdomen, well, I'm primarily looking for soft tissue. Yes, you're probably going to do a soft tissue and a bone. So you can look at maybe if there's any trauma or something to the bone or the pelvis, for example, would be soft tissue and bone, and lung. I mean, the chest would be soft tissue and lung. But primarily the primary task that you're going to use that image for, you need to set the dose and the kernel to match.
And if the clinical task, they want to see everything, want the high-res CT, chest, and also want the soft tissue. What should be the setting kernel in the beginning?
Yeah, soft tissue. And that's just because soft tissue is more dose sensitive. So if it's if you didn't use enough radiation in a soft tissue image, it's very noisy, right? And so if you have a laceration or you have internal, well, bleeding is easy to see, but you have some kind, you got a laceration of the spleen or the liver or something from a trauma case, you need to be able to see the soft tissue damage. Now, if you're going to do soft tissue, bone, lung, you're going to have multiple different kernels. Well, that's okay. Even though we set the dose to the soft tissue, the bone window will be okay. It'll just actually look a little better. And so will the lung. If the primary task is the lungs, for example, if you're doing a lung screening, then we would optimize the dose to the lung kernel. And then if the primary task is, I don't know, let's say MSK, musculoskeletal, then maybe it's bone. And in which case, soft tissue is a secondary look. Now, I don't know if that's true for certain, but for your question, I would almost always optimize it to soft tissue because that's the hardest to see.
Thank you.